my pleasure to introduce the next speaker, who actually Claire knows. I brought Katie to MDD once. I don't know if you remember. Katie is, yes, Dr. Katie Whitcroft. She is an ENT, ear, nose, and throat surgeon, at the Royal National Throat, Nose, and Ear Hospital. And Dr. Whitcroft is very keen on working and explaining to us how looking at olfaction, decrements and thresholds and things like this can be used as a proper diagnostic tool. And it's very exciting research. Not a lot of people understand how powerful it can be, and Dr. Whitcroft is one of them. So Katie, please take it away.
Thank you very much. So yeah, it's a real pleasure to be here, and I'm happy that I'm here because my husband decided to try and fix the router about like 20 minutes ago, and I lost you guys, and I was tethered to my phone, which was not working very well. But let me just try and share my screen and then get my slides up. So thank you very much, Andreas, for the invitation. I really wish I was there with you guys personally. It's always so exciting to hear about smell from a non-clinical kind of lens, because sometimes the clinical lens, and maybe this is just the NHS in the UK, but sometimes the clinical lens seems a little bit stale. So what I'm going to be talking to you about today is the clinical assessment of olfaction. And I want to try and just re-emphasize to you, because hopefully you already know that olfaction is important, why it's important in healthcare. And I want to tell you what we're actually doing wrong. So what we're doing wrong in the clinical assessment of olfaction. And finally, I want to set you guys a challenge because you seem like a group of very intelligent people. So we need your help. I want to set you a challenge to try and develop the ideal clinical test and to try and get that test into standard clinical care. So as Andrea said, I'm a surgical doctor, and I also do olfactory research in London and mainly in Germany. So let's crack on. So I'm going to start by unapologetically telling you something that I hope you guys already know, which is that human olfaction is really important. And I like to think about its role in our lives as kind of a navigational tool. So it helps us helps to guide us through the world of food, our physical world in terms of avoiding hazards, and also helps with social communication, so our social world. And when that goes wrong, patients really experience quite a marked reduction in their quality of life surrounding those three domains. And up to just under half of people who have olfactory dysfunction might go on to develop depression, and what we know is a fairly dose dependent and can be reciprocal relationship. So having olfactory dysfunction can make you depressed, and being depressed can make you develop olfactory dysfunction. It's also really important for some healthcare outcomes, again, which I'm hoping you guys know about. So the development of mild cognitive impairment in patients with idiopathic, or people rather, with idiopathic olfactory dysfunction. And then a lot of those people will go on to develop dementia. And olfactory dysfunction is also linked with all-cause 5-year mortality. And really interestingly, we can see that it's a more sensitive marker of 5-year mortality than other physical comorbidities, for example, having COPD, cancer, or a heart attack. So what we have here is one of, if not the most sensitive markers of general health in older adults that is available to us. So if we're able to find people with olfactory dysfunction and look at their modifiable disease risk factors and target those risk factors, we may actually be able to change their long-term health outcomes. So I hope this sort of reemphasizes why olfactory dysfunction is so important. And we also know olfactory dysfunction is really common. So if we look at data, so this is meta-analytic data from studies that mainly were before the pandemic, we can see that it affects just about 22% of the general adult population, so just over 1 in 5 people, which makes it more common than hearing loss, which affects around 1 in 6 people, or visual impairment, which affects around 1 in 50. So it's important and it's common, and that doesn't even take into consideration, so this is a little bit old, so this number here is probably a little bit higher now, that doesn't even take into consideration COVID, which has created the largest single acute and post-infectious olfactory dysfunction cohort in living history. So it not only has quite significant impact on personal, sort of a personal burden of disease, but it also has a very large burden of disease at the societal level. So it's really important that we identify these people and we try to use this as the insightful tool and sensitive marker that it is. So how do we test human olfaction? Well, there's a number of different techniques we can use, ranging from, on the left, the simplest methods, subjective reporting, and we do that hopefully by default. When you come in to see a doctor, hopefully your doctor talks to you and asks you whether you have olfactory dysfunction or not. Moving to psychophysical tests, so something similar to a hearing test or a visual test. So we give the patient an odorant, and we give them a score based on their perceptual response to that odorant, and we just give them a diagnosis compared to normative data. And then moving to more complex methods, which don't tend to be used in your average ENT clinician's office or your average family doctor's office, because of time, expense, etc. So what I want to look at in a little bit more detail is subjective reporting and psychophysics, because those are the two that are kind of most commonly or most attainably used. And I think this is quite interesting data from an epidemiological study. So this study showed that if you get 100 people, all of whom have olfactory dysfunction, into a room, only 35 of those people are actually going to correctly identify themselves as having a reduced sense of smell. I don't know whether it's the whole driving thing. Like if you ask anyone if they're a good driver, they say they're a good driver. But in any case, 65 out of those 100 people are going to leave the room with potentially the wrong treatment regimen because they haven't correctly identified whether they could smell or not. So that's a really important thing to take into consideration. And this is something that's been borne out in further research. So we know it to be the case. So if you compare subjective ratings to psychophysical test scores in both patient and healthy participant populations, we can see that essentially there's no real correlation between the two. So we know we're not very good at rating our own sense of smell. So it's therefore really important that doctors don't use subjective assessment as the sole tool in their diagnosis of people with olfactory dysfunction, because you're going to miss a lot of them. You're going to miss those people that you could potentially modify the risk factors and reduce their 5-year mortality risk, or you're going to miss out potentially improving people's quality of life. So that's really important. But actually, we don't know what we're doing. The last data from the UK looking at what techniques are used to diagnose olfactory dysfunction is really old now. It's more than a decade old. So along with a panel of clinicians in the UK, we developed a survey. It's called the ICAS survey. And we asked doctors, ENT doctors, what are you doing? And actually, concerningly, this is data specifically from the UK. We had around 217 responses from the UK, but 465 overall. And it was an international survey. Concerningly, in the UK, you can see there are around 55% of ENT clinicians, and this is specialists, are not using any form of psychophysical tool or smell test in their assessment, in their initial diagnostic assessment of people with smell loss or olfactory dysfunction. So that means they're just asking them. And we know that 65 of those 100 people are going to be incorrectly or misdiagnosed because of that. So my challenge to you guys is to develop the ideal clinical test and to make that clinical test a standard of care. So the ideal test is going to need input requirements satisfied for both the clinician and the patient. So let's look very briefly at what the clinician needs. So psychophysical tests can broadly be divided into orthonasal tests and retronasal tests. Retronasal tests being the perception of flavor essentially that you get when you're eating and drinking. And that is a very niche test, which isn't really done outside of very specialist centers. There's probably one in the UK, a few more in places like Germany, but no one essentially does it. So I'm going to talk to you just about orthonasal for the moment, which doesn't necessarily mean that we shouldn't be doing retronasal, but anyway, we'll talk about orthonasal. It can be divided really broadly into tests of the odor thresholds, the lowest perceptible concentration of an odorant that's detectable by a patient, and super threshold tests. So super threshold tests tend to ask questions about the quality of an odor. So probably the two most common types of super threshold tests that are used is odor identification. So you give someone a smell and you say, what is this? Is it an orange, a pineapple, a lemon, or a pear? And they have to give you an answer. Or odor discrimination, where they have to tell you whether a smell is the same or different to another one. So they have to discriminate between them. So threshold and super threshold tests, as I say, those are the most common ways of testing orthonasal olfaction. And if we look at the available tests that are actually used clinically, and these are used in the research environment as well, you can see that there are a number out there. There are a lot of different ones out there. In fact, there are more than this. This is a slightly old table now. And each of them is looking at something slightly different. And whenever I sort of got into olfaction a few years ago, I was trying to figure out, because I'm reading all of these research studies, and they're talking about outcomes potentially even for the same medication or the same therapy. And one test is talking about the outcome according to odor threshold, and the other is talking about the outcome according to identification or maybe discrimination. So I was a little bit confused about whether these different aspects of olfaction are interchangeable. And actually, some other people have looked into this, one of whom is Dick Doty, one of the big names in clinical olfaction. And he, almost 30 years ago now, used a principal component analysis and said, well, actually, these seem to be measuring a common source of variance. Therefore, they're probably interchangeable. So it doesn't matter if you test for identification or threshold. But actually, this isn't really holding quite so true anymore. There is an increasing amount of data from sort of lesion studies, from studies correlating psychophysical tests with measures of cognitive function that says, in fact, actually, probably what we're seeing is super threshold measures, so identification, discrimination, things like that, tend to best reflect central pathology, so pathology of the brain. And threshold seems not to correlate so well with those pathologies. Looking at patient cohorts, we then found, so it's some work that I did in 1,200 patients, we found that in patients with problems with their nose, this seems to cause most strongest effect on odor thresholds. So we're starting to see this pattern emerge where peripheral problems with the nose tend to be better correlated with odor threshold, and problems with the brain, so central pathology, tend to be better correlated with super threshold tests. And you guys will understand this more better than me. Can't speak either, excuse the grammar. But this is unsupervised machine learning, which showed that odor threshold is actually quite a sensitive measure in discriminating between different clusters of emergent subtest patterns, subtests. So by that, I mean the score you get on threshold discrimination and identification. So from this, we can see that threshold is probably quite important to do. A super threshold measure is probably quite important to do because they give us different information. So those two things are probably what we need in our ideal smell test. So we need to bear that in mind. But what else do we need? So we went back to the survey and asked clinicians what other aspects of testing were important. And it seems that in terms of barriers to smell testing, the sort of big ticket issues surround service provision. So if you've ever been to an NHS hospital, you'll know that it's crowded and there's no time and there's no money. And those are basically the problems with doing smell testing. And additionally, clinicians usually don't want to spend more than 5 to 15 minutes doing smell testing. So the next thing I wanted to do was just very quickly look at what patients think. So no one's ever asked patients what of the clinically testable aspects of olfaction are most important to them. So in collaboration with Absent, which is patient charity, we did a survey of almost 600 patients with olfactory dysfunction and asked them what was most important. And what they tend to prioritize is their ability to identify odors and their ability to identify flavors. So that might have something to do with kind of autobiographical memories, episodic memories, nostalgia, sense of identity, sense of self, but those two were the most important to them, followed by detection of odors. And then finally, patients will essentially spend as long as is required to have their sense of smell test. That other little exploded segment there was people who said that they would spend all day if required. So the ideal test needs to be efficient, affordable, and informative for the clinician. It needs to be available for the patient. It needs to provide insight into their condition, and it needs to provide some insight into their ability to identify flavors or odors. So finally, I just want to leave you with this thought. If you had a problem with your hearing, you wouldn't be treated, you wouldn't be given a hearing aid without having a hearing test. If you had a problem with your vision, you wouldn't be given glasses without them testing your vision. So why are we treating patients with olfactory dysfunction without testing their sense of smell? And the other thing is, if we are able to do this on a wide scale and identify those people in older age, we may potentially be able to help those huge numbers of people out there with potentially modifiable healthcare outcomes. So that is it. I want to say thank you to Chris Kelly from Absent for her help with the surveys, and to Thomas Hummel, who is just an all-around good guy. Thanks very much.
Thank you so much. Okay, thank you. Katie, do we have questions from the audience? Someone? No? While you're getting ready, I'll ask the first one. Katie, you are one of very few people who have sort of seen the light about this. You've seen the power of using people's psychophysics. By the way, for the audience, psychophysics is not the physics of psychos. Okay, it's an old term that has been sort of gone. You know, it was in the back burner for about 100 years or so. But since Weber, this is the psychophysics means the study of the apparatus that allows humans to perceive the world. So things such as how strong must a difference be between two signals before you can tell them apart. And Weber famously in the 1800s, Katie probably knows the correct date, determined very interesting things, such as if you give you two masses, they have to be at least 50% difference in weight before you can tell which one's heavier, which is a huge number if you think about it. So a lot of these things, you don't understand how good you are at something or how bad you are. And we have a psychophysics workshop in a minute. But Tristan also has a question. But let me finish my question to Katie. Please. Katie, why are there so few people like yourself? I mean, clearly you're getting traction out of this. You're getting effectiveness. You're addressing your patients' needs better. You're getting publications out of it. Why are there not more people doing this?
Well, there are more people doing it now than there were before the pandemic. There's certainly it's a very dynamic clinical research space in olfaction at the moment because of the pandemic. But similar to what Claire said before, I feel like the interest is slightly waning. So we're going to see who sticks around. I was here before the pandemic. I don't know. So it might be a problem with the fact that ENT surgeons are the people who tend to see patients with olfactory dysfunction, and ENT surgeons are surgeons, and surgeons like to have things that you can cut out and things you can sew back together, and they like to have very defined outcomes. And well, one of the problems in olfaction is that we don't know what the outcomes are because we're not using the right test in the first place. But it might be that because of the kind of the clinical specialty that deals with these patients, and because of the nature of surgery being what it is, it's kind of neglecting the fact that olfaction is a hugely interdisciplinary kind of area. And in order to understand olfaction, you need to understand a little bit of neuroscience, you need to understand maybe a bit of psychology, bit of psychiatry. So maybe if those patients were primarily seen by neurologists, which I know in the States sometimes neurologists do, but I don't know if they're 100% better. Maybe if we had more of a multidisciplinary approach in the clinical world, then we would be making more progress potentially. I don't know is the basic answer to that. I think it's fascinating.
I really like your answer. Multidisciplinary approach in the clinical world. This is where it's going, but the doctors are kicking and screaming while being dragged into that. They don't like this at all.
It's because most multidisciplinary meetings we have is about old people who need like handrails in their house to help them get up and down the stairs and stuff, and they take a long time, and they've got a bad rap because of that. Whereas I think an olfactory multidisciplinary meeting would be so exciting and everyone would love it.
Yeah. Okay. So Tristan has a question for you.
Yes. Yes. So Katie, I actually showed a slide yesterday about a project we are developing with Thomas Hummel about a prosthesis for, you may have heard about it. I'm from Haribal in France. But my question...
Yeah, I've heard of this project, yeah.
Yeah, this is a long and futuristic science, but very simple question actually about this retronasal test. Mm-hmm. Because indeed, man can imagine that before being able to smell with their nose, they may also want to know if they can taste well with their mouth while eating, right? So what about small, little, not too sweet candies as a...
Yeah, so that's actually... That is a currently used retronasal test. It's called the candy smell test. And they look the same, and you give it to people, and it'll either be orange or strawberry or something like that. But it's very, very infrequently used. The problem with retronasal olfactory tests is that obviously flavor is a composite perception from taste and smell. So most retronasal olfactory tests use something that you eat. So either candy in the candy smell test, or the flavor powders, or something of that nature. And in fact, a lot of clinicians will just go to the grocery store and buy, for example, ground instant coffee, and have people taste that and tell them whether they think it's coffee or not. And the issue with these is that you have confounding from the tastants. So for coffee, for example, it's very bitter as well. So the concern is that people are tasting the bitterness of the coffee, and they're identifying it based on that as opposed to the flavor. So the retronasal olfactory input. So there's a number of ways that people are trying to get around this. There are some tasteless stimuli that are being produced. I don't exactly know how they're making these, but apparently they're things that you can taste, that you can't taste, but you can smell. And then there's slightly invasive sort of applicators. So basically tubes that you can put into the oropharynx that bypass the tongue essentially, and they release a little bit of odor, and it gets to the olfactory neuroepithelium through the back in the same way as it would get there when you were eating and drinking. The problem with that is it's less ecological in terms of the anatomical biomechanical process of eating and drinking. So if you've got a tube in the back that's puffing something out, it's not going to be as realistic in experience as if you're eating and drinking. So maybe the tasteless flavors are the way to go. But certainly it's an area that's not tested enough, but really given the complete lack of testing by anyone for anything, that's kind of being shelved as a second line target to approach after the kind of orthonasal testing as a first line. Does that answer your question?
Yeah, very clear. Thank you very much.
Thank you. Do we have other questions for Dr. Whitcroft? If not, let's thank our speaker again and introduce the next one. Thank you, Katie. Wonderful.
Thank you.